We lived in like California or someplace where it'd be shocking.
Yeah.
So I'm.
You went, any lights dim, this is good.
Are you guys okay?
Yeah. 26 would be our last day.
Thank you.
All right, enjoy, guys.
All right, shall we? So I've got two things before lunch. Don't eat dessert. We'll have dessert with hepatitis. Wait a minute. We'll have hepatitis with dessert. Wait a minute. No, we'll have hepatitis lecture in. So that'll be after lunch. So I'm Dr. Julius, and I am director of the lab over Mahoning Valley and director of the blood bank here. I live in Youngstown. Which, if Ohio's the heart of it all, Youngstown's the heart of the heart. Okay, anyway. So if you're not from Youngstown, well, I'll look at you, but I won't judge you. So anyway, all right, anyway. So I'm going to tell you, we're going to do two things. We're going to talk about HIV. So if you've heard about the disease, when I was your age, it was just being discovered as to what it is. But I want to talk about it and why these people don't have an immunologic response. What is it about the HIV virus that causes their immune system not to work? Second, we're going to do a quick overview of COVID. You've probably heard a lot about it in the last 2 or 3 years. And so in this particular case, it's like, why do certain people have different COVID reactions? And we'll talk about the immune response. But let's start off with a couple of things. And you may not, I mean, it's kind of introductory, but you may not have had all of this. So if we're talking virology, where does a virus do its business? I mean, extracellular or intracellular? Right. Okay, so here's a cell sitting on, it could be a hepatocyte, which has tropism for HIV, for hepatitis A. Could be a back of the throat larynx, which is corona. You know, it's certain tropism for cells. HIV likes to infect the immune cells. That's why it's bad for the immune system. But anyway, here's the material and here's the virus. So the virus first has to get in and then takes over the cell to make copies, maybe even to damage the cell. So how do you get rid of a virus? What do you do? Get rid of the cell. Do you know what cells get rid of a cell as far as an attack on a virally infected cell?
Lymphocytes.
Nice, perfect. Lymphocytes, CD8 type. Okay, so they're T cells. So CD8s. So part of your response in hepatitis is your immune. You get infected, someone goes, they have a terrible hepatitis. That's because they had a terrible inflammation, which is itis of the liver, hepatitis, because of their immune response. A little kid gets hepatitis, they get a carrier state. Their immune system goes, well, that's just us. This virally infected cell, that's just us, I'll tolerate it. Whereas an older person will say, oh, I'm going to kill off that cell. And so it is not the virus as much as it is your immune response trying to get rid of the virus. So then what protects you after CD8 kills those cells? What protects you for the next time the virus comes? Correct, which you get from what type of cell? Perfect. Okay, so a T cell, CD4, helps the B cell go to a plasma cell and make immunoglobulins. So the next time down the road, next flu, whatever season, you get the next virus, you neutralize it before it ever gets to the cell. Okay, so you have your first infection and then you have immune memory. So why do we give you a flu vaccine 2 months before flu starts? Right. We're not going to give you the infection, but we're going to give you hopefully antibodies and get you through that antibody production. Maybe some IgM, then IgG, and you'll be ready. Even if your IgM, like here's your immunity, here's your shot, here's your IgM, here's your IgG, and then here comes flu season and you get the flu, you have this quick response, which is called the anamnestic response or a memory response. So what we want to prepare you for is not getting the virus, getting it neutralized. All right, does that make sense? So that's kind of viral infection in a nutshell. So let's do one other thing. So that's what we do to viruses. So if I said coronavirus, you would say RNA or DNA? RNA. Okay, so it's RNA virus. And to make the virus, I need the RNA and I need the viral capsid or proteins or antigen. So when I infect somebody with the virus, it'll sit there take over the cells. You go, I don't feel so great. All the interleukins, because the body goes, there's something wrong here. We're trying to get up the immune system to fight it. But meanwhile, here goes the virus, and all of a sudden the virus will say, hey, we're going to make copies. Well, it will obviously copy this, and it will copy this. And I'll show you, you can either do an antigen test for the protein, or you can do a nucleic acid test for the virus. Okay, so sometimes the nucleic acid will come first. And then here comes the virus as they package it. And then now you have intact virus that you could detect. And then, of course, if the person starts to make immune, you can say, hey, I'll get the IgM here, and they're infected acutely, or you'll go, hey, it was 2 months ago I had this bad illness, and you'll say, oh, because you have an IgG, you saw this virus, so that's what that virus was. So here's your response. But here's the production of the virus. So in any viral infection, virus comes in and says, I want that cell. Takes a while, your body goes, there's something wrong with that cell. You're marshaling the CD8, CD4s, and Bs, all of which will have different time elements as attacking that cell and protecting you. So you'll attack the cell, then you'll protect. So here's your Bs and CD4, here's your T8s trying to kill off the viral infected cell. But the virus will say, I live for this. You know, it's like they take over a factory and they're just going to make as much virus as they need until your body catches up. So that's a viral illness. So how do we detect it? 2 ways. Your response, which we say is acute or chronic or memory. That's with every viral illness. Or the virus's response, which is a lot earlier. I feel kind of crappy. Hey, you have an antigen or you have the nucleic acid itself. And this is where we got into with swabs and everything with COVID. So you're going to see that when we get into that lecture. Fair enough? Okay, so that's virus. So how do you get a virus? Oh, sneezing, talking. I mean, droplet spread, right? We're going to spread one to another. So a virus doesn't do really well on a surface for a long time. Bacteria can love and grow on a surface. And you get your bacteria from biofilms and things like that. But virus usually is going to die off, a lot of them, unless it's acute. They just did a study talking about what, and I thought this forever with COVID. COVID showed us 2 things. We're overweight as a nation. So there's the inflammation of the people between kids and adults. Kids go, give me a virus, I don't care. I'll give it back to you because they're usually healthy. But the older folks will talk about their inflammation. But in between, you had people who were getting sick. Those are people who were bigger or obese and had an inflammation that we'll talk about. So that's one thing. The second thing is we don't have really great rooms. You know, we talk about sick buildings and we talk about air. Like, is there air moving in this, you know, and filters and things like that. I ate at a restaurant down in Gatlinburg in 2021. They never closed during COVID. And the guy told me, he says, as soon as COVID, he said, we upgraded our entire air handling system. We put the filters in, we increased the amount of air we bring in from the outside, which is the reason people died outside. And there were just some studies that I think it was shown in 60 Minutes. The study was shown on 60 Minutes in the last couple of weeks. I had read the study, but this scientist was talking about the dwell time of just our talking in closed spaces, and was talking about the choirs that sang together in a church that didn't have air going and how they infected each other in the early parts of COVID. So how do we infect each other? An infected person brings it to work, brings it to wherever, and you have the chance of being infected. But I say that you could sit right next to someone who's infected and not get it. So is that your immunity? Is that because the virus is heading this way and not to the side? But again, what we're doing is we're usually giving it from viral spread from an infected person to another person. And that's good. Yeah, that's spreads. All right. All right. So there we go. So we talk about HIV, human immunodeficiency virus. So it is called human T-cell lymphotrophic virus number 3. Lymphotrophic, that's what it infects. We just said the lymphs are very important. This one says, I'm going after the T cells. So the infected agent in HIV is the T cells. Thus, your immune system goes down when you have HIV. So let's talk about it. So if you look at how many people are infected with HIV, 1.2 million. I lived through when it was in hemophiliacs. I lived through, it was significant in homosexual male population. They were big time blood donors before 1980. And in 1985, they were taken out of the donation process. They have been put back as individuals as opposed to a whole group. You really have to screen people one by one for their risk factors, but are being brought in depending on safe sex and otherwise. But anyway, these are the issues. You can get it in children. Of course, children would have had an infected mom. When you look at, you can just see socioeconomic disparities. You can see you still get all types of individuals in the sense of ethnicity. And they're represented roughly in the population, but this is an overrepresentation for African Americans. So that obviously is a socioeconomic issue, either the ability to get to care or to receive care. It shocked everyone in 1990. I was at the American Association of Blood Banks meetings. You guys were there. But and Magic Johnson announced that he was HIV positive. To that point, no heterosexual individual, and he had numerous sexual encounters as a basketball star, and no one had reported that. There had been cases, but it was really focusing on like hemophiliacs who were getting tons of blood products. They were getting human-derived cryo, and they were making their factor VIII and injecting it every day. And so they get 10,000 donors to come into a pool, make their factor VIII. 10,000 donors in that. One infected donor infects everybody who injects that. So it is now recombinant. It is not human-based, and so they're safe. But a whole population of hemophiliacs used to get injections every day and they got the HIV. Then it was seen in the homosexual population, predominantly male homosexuals. And at that particular point, we were thinking that was the group. And then here comes this case was, but it shows you the success of the therapies because he's alive 33 years later. So it's very interesting. Sexual contact, mom to baby by blood, and of course, blood contact. So mostly blood. And we treat, when you look at OSHA standards and someone says, why do you have that biohazard bag? You have it for hepatitis and HIV. Does everybody have it? No, but you're supposed to treat it like everybody has it. So you don't sit there and go, oh, this is my friend, I drew her blood. No, I mean, you got gloves on for everybody. Okay. And that's how you're supposed to treat blood and body fluids as a laboratorian for splashes, for mucosal exposure, for hitting yourself with a needle or otherwise. So everybody's blood is though it is HIV or hepatitis. That's why I got the biohazard.
I know you stated in the beginning of like HIV coming out, it was more in the homosexual population. Why did like scientists and doctors assume that? And what was why was the mechanism of spread and why it was mainly seen in just that population?
The mechanism of spread was sexual transmission, but it was also anal sexual transmission where there was a lot of bleeding. And so it was almost like a direct, instead of mucosal exposure, which was the heterosexual by secretions and otherwise, it tended to be more blood, with sex. And so that was a big population that was studied. And actually they were dying of pneumocystis pneumonia, and everybody said, no one dies of this. And they were finding these cases. So they found clusters of pneumocystis and opportunistic infection in hemophiliacs and wondered, what the heck is that? Blood being injected. And then the other, and it was more anal receptive sex. And it just happened to be in that population more so. All of it came in West Africa. So there was a Rolling Stone magazine article way back when talking about the frequency of air travel and how individuals from the United States brought it back from a heavy endemic area in Western Africa. So when you talk about where HIV kind of burgeoned, it was in the West African nations, and then it came back from travelers to all the world. Oops. So now I'm kind of going to forward. Yeah. So at-risk population, and this goes right to what you said, the unprotected sex. Now that can be unprotected heterosexual sex, as we've seen. Then IV drug use came along too. So it really fits a viral pattern, a bloodborne viral pattern. Here is a group of people who may not be privy to this or may be higher with regard to IV drug use or otherwise, and this comes to socioeconomic issues. This was one of the biggest populations early on. Not so sure about that one. And then substance abuse, because usually one substance abuse can lead to other substance abuse, including IV drug use. So it just can be associated. A lot of prisoners, a lot of male prisoners, commercial sex workers would make sense just for the high propensity of individuals that they're associated with. So it shows you it's a sexual transmission, it's a blood and body fluid, it's a viral transmission. So when we were sitting there talking about coughing on each other for corona, in this particular case, it's spread by sexual transmission and those secretions and blood. So you get an epidemiology of how something is spread. And here comes your healthcare workers. And of course, you can see a less than 0.3% chance, but we also have OSHA that came up really big in the 80s and the 90s that told us, be careful for a hollow needle stick. We have bags, we're treating everybody as though they're infected. And you can see we don't have a lot. We also have needle stick protocols. If you work in the ER or as you go down and draw somebody, you get stuck, they're going to test this person who you just got stuck with and test you baseline. Maybe give you some medications to stop it at that point. The acute infection looks like mononucleosis. How many of these we never recognize? It's hard to say, but this looks like mono. Might have a rash, but a fever, malaise, and otherwise. I had an interesting case back in the 90s. It was a dedicated platelet donor. He had donated 23 gallons of platelets. So he was coming back from a business trip and we wanted to get him for baby. And the baby was at Nationwide Children's. And so we said, hey, we know you, baby needs this, matches your type, could you donate? So we donated. And since we had known that he was, a safe donor, we assumed and moved the product through and were getting it released, getting it ready for the kid to give it to the kid. And his HIV positivity came up as positive. So we asked him what happened, and he had been with a couple of prostitutes 2 to 3 weeks earlier on a business trip and came down with a mono illness. Didn't say anything about the mono illness. We called them and said, please donate. You're a great donor. We know you're safe, which a blood donor is only safe as your last needle stick or exposure. And we asked those questions. We asked pretty intimate questions if you're donating blood today, which there is a blood drive over in the Constantine building. And so then we tested the kid. We tested the kid. The kid was okay, thank the Lord. But so he was in the acute phase, which didn't make him shedding virus, but it made him getting virally infected, if that makes sense. Because remember, the virus has to set up shop first. Okay, so it has to find its cells, then it starts making virus. So you're going to go through a period where it's just in you, then it's going to be out in blood like hepatitis or out in blood like HIV. All right, so we can do different surveillance to define an HIV or an AIDS. And if you're greater than 18-month-old, then obviously we're going to test you for antibodies. We can also test for antibodies to specific antigens. We now can go back and do nucleic acids on folks, and so we can test. Now, these are the things that used to tell you it's HIV, where you got very strange infections. In other words, your immune system was not like other people. You were getting candida of the esophagus or candida of the bronchus or down here the pneumocystis pneumonia. These are things that healthy immune systems don't get. And so it gives you the idea that they have an altered immune system. The cell of attack is a T cell. Okay. And these are the opportunistic infections. Cytomegalovirus, right? Retinitis, histoplasma, even tumors. This is Kaposi sarcoma. You can see under the skin, there's a spindle cell tumor, and it's this particular sarcoma, and it can be promoted by HIV infection. In other words, kind of an opportunistic malignancy. So you can do different tests. Here's that nucleic acid. Here's the protein or antigen. We don't really do viral culture. And then we can go back and look at antibodies. But when you look at someone who's very, very, very young, so if you have a kid who's born and you're going to test a kid, a newborn or otherwise, if you test for antibodies, kids don't make antibodies because they have an immune system that's not up to speed. So you're testing wrong. So how do you test a kid? Let's see if they are shedding virus. Let's see if they have that virus, because virus is going to come before any antibodies. And as far as the kid is concerned, they're not going to get antibodies for a while anyway with their immune system. So it goes down into detecting the specific HIV, HIV RNA. And so that's what you're detecting. Anyway, you can obviously ask a lot of history. We ask a ton of history for mom. We test hepatitis in mom. We can also, ask any other significant questions. So when we look at HIV, the early HIV infection, you may just have a negative test because the virus really isn't yet to start shedding. And then you can get all the way to the point where you have AIDS, which is acquired immune deficiency syndrome. So I was born with a good immunity. HIV is now, as an acquired, making me immunodeficient. Why do we call it a syndrome? Because we bring together a lot of stuff in a syndrome. You go, what's Candida, pneumocystis? It's all under a big umbrella of a syndrome. You'll hear symptoms. And here's the cell counts that we used to do. This is a while ago where we would look at, depending on the age of infection, age of the person, we would basically look at their T cells because that's the cell biggest attack. So we just said CD4 helps you with your antibodies. Well, there's no more help for the antibody there. And there's no more help for antibodies against a lot of bacteria. And so those are the opportunistic infections. So you're freezing the immune system. You're infecting the immune system. And it comes from a retrovirus. So it starts off with RNA, goes backwards to DNA, and then by reverse transcriptase. So any virus is going to say, I'd love to set up shop in a cell. That cell for HIV is a T4 cell. What it needs to do is say, forget your actions, T4. I'm going to use all of this cell for me, which means I'm going to intercalate into the DNA. I'm going to use it to make more copies. I'm going to use your protein in your ribosomes to make more antigen. I'm going to put together viruses, and eventually you might even lyse the cell. So the cell will be used and thrown away. Okay, so that's what can happen. And this is what HIV, this is what the virus looks like. So have we seen enough viruses? We said this was my coronavirus, desk thing, because we've seen so many pictures of it through the years, but we really didn't pay attention to what viruses look like. But this is what they look like at the electron microscopic level. And you're going to be able to bind the same way as you bind by spike proteins. These are going to be GP 120 and 140 on the envelope. This is all protein. And your RNA is going to be in the inside. So your nucleic acid test is about innards. Your antigen test is about the outards, or the proteins. Okay. And so you have envelope proteins on the outside. You can make, so any of these can be identified, but you make antibodies to these, or you make antibodies to this one. And then all the other ones, when it comes to polymerase, it allows you to use the DNA, go backwards, intercalate, take over the cell, and I'll show you some of those pictures. So Africa and West Africa coming out of a lot of different viruses in that region, spreading worldwide. HIV-2 tends to be more continental Africa, can also be a little bit of South America, but HIV-1 is pretty much worldwide. And so what you end up seeing is a lot more HIV-1 of different types and groups. And there are most commons. There are geographically restricted. There are really never moved kinds, and otherwise. And so this is what you end up seeing. And the simian viruses, kind of a co-infection, is what you've seen jumping over into humans, and then ultimately being discovered and carried around the world. Let's see what I would want to say here. Well, HIV-2, that's the biggest thing, is heavy in West Africa. So there are questions. How many people donate blood? It's about 5% of every crowd. But when you donate blood, you'll get some very, it used to be the most intimate question we asked was your weight. We had like 3 or 4 questions, and I asked the weight, and the woman said, I am shocked you're asking. But now we ask, have you had blood? Have you had sex with a person? Have you had tattoos? And all of those are to evaluate for the risk of blood-borne infections. And for a while, when we didn't have the best test for HIV, we asked about travel. We said, are you from West Africa? Have you had blood products when you were living there? Because that's from the population. And we would have to epidemiologically cross a lot of people out just because of their travel or otherwise. But if you've ever donated, we ask some pretty significant questions. And the whole point is, can you get rid of someone who might have a risk, or tell them to wait a year or half year and come back? Because if they were in the middle of an HIV early infection and didn't tell you, didn't feel like it, like my donor was, you thought, oh, I just had a cold or I just had mono, then you are going to be negative falsely for the nucleic acid, for the protein, and you have yet to make the antibody. Thus, an infected unit can make it into the donor population and then be given to a patient. And so the whole goal for FDA, they said, I hate to tell you, you're going to throw out baby in bathwater. If you have any risk, you're out. And I've seen very healthy people who have been excluded for a while or otherwise, who said, I didn't receive anything, I just lived there. And they used to say, if you lived there, or if you were from a certain part of the Caribbean or otherwise, where there were higher incidents of HIV, since we didn't have great tests, they said, we're going to take you away just by where you live. And that's a lot of classification. You just basically said, anybody who lived there, and they're going, wait, I wasn't in the sex trade, I wasn't doing this, I didn't get blood, and they'll go, that's all right, you live there. And so what we're getting now with some of the better tests is we're testing every unit, but we still ask some pretty good questions, and we do it for the risks. Here's your main cell, T helper. You already told me T4 was helpful, but it can also affect monocytes and macrophages, dendritic cells. These are all antigen presenting cells. It can get up into the brain. So HIV can be in the brain before it really does a lot in the rest of the lymph nodes and tissue. Reverse transcriptase is what produces DNA from the RNA, goes backwards. Instead of making DNA to RNA to protein, it opens up a protein, uses the RNA, and then produces DNA. And then the viral DNA goes into the nucleus, it integrates, and then basically you're off and running for replication. So we'll talk about a few parts of the infection. The viral proteins, that's the stuff that makes the outside. So when we talk about tests, nucleic acid test, antigen test, which one's the protein? Antigen. That's the outside. So if I make a P24 antigen, I'm making copies of virus. If I have HIV RNA, I'm infected with virus. If I can find RNA floating in blood and protein floating in blood, I probably have intact viral particles. Would I have an IgM or an IgG yet? I may not, but it tells me they were infected. And of course, we see that really with coronavirus, where they said, we don't have time to have you make an antibody. We want to know if you're infected right now. We want to find antigen. Because you would make antibody a few weeks later, but they go, by then you would infect everybody. Okay. Very different than in this case. You're dealing with an infection. It would be blood that would spread it, not coughing, not breathing, not coming to work or otherwise. So it's a different epidemiology. And just stop if you have questions. But here's that thing that I was showing you about. You would get a certain infection. So blood splash on a mucosal surface. Viral particles in that blood. Antigen presenting cells say, hey, there's all this foreign protein on the top, on your eye, or you have a needle stick. And it takes it to the lymph node and says, there's some foreign protein. HIV is now in. Now it says, hey, wow, T4s, that's what I want to get at. And T4s are obviously antigen presenting cells as well. And so basically it's going to get into those cells. And as it gets into those cells, notice for a while, you don't make viral particles. You don't even make RNA. This is when it's starting to find the cells that it needs and setting up shop of infection. Once it sets up shop, now you're starting to make RNA, intact viral particles. You're starting to see higher copies. You are viremic. You're now infective. You're being infected, but you're infective. Okay, because any of your blood right now can have the RNA, can have the intact protein, has virus. Do you have antibody yet? No, but I'll show you it's really tricky when it comes to HIV, because you make antibody for a while and then HIV can, if untreated, can actually win out in the end. But here's where you are positive for nucleic acid. Here's where you're positive for the earliest antigen on the surface. Here is where your antibodies start to be positive, and Western blot is a way of doing an antibody test at specific antigens. And you go forward. But notice there's a point in any viral infection where you feel crappy, something's wrong, something's brewing, but you have yet to really have the virus set up shop. And think about it, this is a lag time as your immune system is going, hey, we got to go after this virus. The whole point of immunization is that you can shrink this time period and maybe not even establish infection. Okay. So there are different phases. You can see how it ramped up in amount. A window period would be where you don't have antibody yet, which would be like right in here where you'd have antigen, but you have yet to make the antibody. These are what you see. So look how early you can see the start of making RNA and intact virus before you would make antibody in the third stage or otherwise. And you can see, you're in the early stages here, you're out a month or 2 months or 3 months for some of these other ones. So it's setting up shop. And this is what happens. So what ultimately happens, and this is what happened when there was no treatment. The CD4s would be infected. You would make your viral copy. You would then make your antibodies when you had CD4. But as continued virus progresses, notice CD4 gets less and less and less. Now this is over a few years. Antibodies now don't have any help. So here come the opportunistic infections. And many of these folks died of those opportunistic infections because they didn't have the T cell help. So bottom line, HIV infects your immune system. The cell's T4. And now we'll go through like what that does and what we're going to do. But I'll tell you a few things when it comes to detecting antibodies. You can detect antibodies or antigens. And the detection tests, like say for instance, we have a well. That well may have an antibody on it. That antibody would be to an HIV antigen. Likewise, it might have HIV antigens to trap the patient's antibody. And what I'm going to do here is send another antibody down. And then I'm going to send an anti-antibody that has a signal. So that signal will tell me there was an antigen here, or else it wouldn't be there because it wouldn't be sandwiched. They have antigen positivity. It would tell me they have an antibody, because if that wasn't there, you wouldn't have this signal. So we rely on sandwich techniques or signal techniques to either capture and expose an antigen. Hey, they got an antigen positive, or capture or expose an antibody response. And that's true across the viral testing. Very different than the nucleic acid. Now you're in the PCR and all that other stuff. You've gotten some of that stuff. So when you absorb, it depends on what you would want to trap. The antigen in the patient, or any of these others, solid phase, you can put them on polystyrene, you can put them on particles or magnetized particles. There's a lot of different ways to separate from the plasma the patient's antigen or the patient's antibody. And then how do you detect a radioactive antibody, an enzyme antibody, a fluorescent antibody, any of these things? This is chemiluminescent and this is fluorescent. So basically you're saying, I want a signal. The signal is only there if this particular signal antibody finds what it needs to sandwich between what is on your tube, your ball, or your well, and what you're looking for. Okay. So here's the test. So here's what we're talking about. If you were looking looking to pick up an antigen, all right. So this is the antigen right here. So this is all set up. This is coded. This is patient specimen. And in it comes the antigen. Once the antigen binds, here comes your sandwich detectable antibody. So that's going to have your chemiluminescent, your radioactive, your color change, whatever the case might be. If this is there, there's signal. Okay. Flip it around. I'll put an antigen on them. I'd like to see if they're making an antibody to this virus. You throw in the patient's serum. The patient does have FAB right towards that antigen. You then capture this with an antibody. So this is an antibody to the antigen, but labeled. This is an antibody to IgG. And you could say, I have a signal. The only way you ever get this signal, okay, is if the patient has this, the patient has this. This is virus, this is antigen, this is viral particle, this is immune response patient antibody, okay? That's basically what you do. And you'll be looking at color changes and you'll be looking for absorbance changes based on the tube and based on the system. So you have to sandwich it. That's the reason for the term. But that's how we do a lot of viral tests. Why didn't it work in COVID? Because we didn't have a good antigen capture. And if we waited this long for the antibody, that person's probably already over the infection and had the 4 or 5 or 10 days in which they infected. So what did we do? We went back and said, you know, we're going to get nucleic acid, which is also a test of HIV. This is antigen antibody, but let's go a little further. So then if we were to look at antigen antibody, and this goes through these years, this is the reason we ask those questions. In the first generation, we used to detect IgG. That could take a month or two. So we used to do this. People get a tattoo, and we weren't sure if it was a regulated place because we didn't have a lot of regulated places back in the 80s, and that was a blood reaction. We would say you're deferred for a year. And that year is to say the next time you come back, you could have IgG. Certainly doesn't help the person. Helps the potential patient who would have gotten their blood, but doesn't help the donor. Now we write letters to donors and say, you might be early infected, and we can maybe potentially help them if they didn't think they were exposed. But you can see we went through 1980s, 90s, just detecting the immune response for HIV. Then we got back and said, hey, you know what? Let's detect the first immune response. Let's see if we can capture IgM. And now, as we've gone to 4th and 5th generation, we can not only find the antigen test, which tells you a little earlier than the immune response, but the immune response, IgM and IgG. And now you can actually sit there and figure out if they only have antibody or only have antigen. So we're shrinking that time period. And that's how we would test a donor. And why do I mention donors? Well, donors are blood. This is spread by blood. And think of what happens in donors. People just roll up their sleeves. We do not know who they are. They may not be paying attention to their health. Yeah, I don't feel great. And there's a question if you donate blood. Do you feel good today? You know, I mean, you wouldn't be donating blood if you didn't. But believe it or not, some people go, well, I don't feel great, but yeah, I thought I'd come and help. Well, and that's great, but you want to be the best you can be for the sake of the patient who's going to get your blood. So when we look at blood, there are 15 million donations a year. And we don't know anybody. We don't know risk factors. We don't know. We can ask them a few questions. So we're basically saying we assume 15 million people are healthy. In that group, there may be some people who are unknown to them infected, or unknown to us and them, false negatives, and they really are infected and they could infect a patient. And so we ask a lot of tough questions in that case. Flip it around. If you go to your doctor with an abnormality, he or she knows who you are. You say, I feel horrible. This is bad. It started Tuesday. It's a more designed test for you. So then someone would say, well, what's your risk factor? Well, I might have done this or this, or I spilled blood, but I didn't tell anybody at work. And you're like, all right, but you feel terrible. Well, then that doctor might say, you know, we need to do nucleic acid test because maybe we can get in and treat you early. Now, if you tell somebody you have a needle stick, you'll be treated by the hospital. But if you hadn't and you came in, I mean, that's what, you know, that's what's going to happen. So when you look at some of these, this is the years that happened. How many people know Arthur Ashe? Do you know who he was? No. You ever watch tennis? This might happen. But anyway, Arthur Ashe was a tennis player, and they named the stadium after him for the US Open. He had open heart surgery in 1985, New York Blood Center, the height of HIV. He died of HIV because he got 4 units of blood when he was on the open heart machine. Then he developed HIV when there were no drugs, no good meds, and died within a few years. But that shows you what we were back at in the early 80s. We had a test just for IgG. So if I did that on every blood donor, fantastic. But if they came in less than 10 weeks, less than 8 weeks, didn't have an immune response yet, any of these donations earlier could be infected with HIV, but undetected by the blood center. Okay. Here's where we developed into plates and better assays, but you can see it's always that sandwich technique of the antibody response. Only when we got to the fourth generation could we do the antigen and the antibody in the same patient. We could say, did you just get infected? Do you or do you not have antibodies? And those are, and of course, we grew them up in recombinant or synthetic. So we grew up the antigen, put it on the well. You know, it's not coming from a patient, it's coming from the proteins on the well that we can put. And many of these allowed them to go on different assays and different, like the Architect's big for immunology assays. You know, we can test for, again, P24 or HIV1 or 2, increased sensitivity, and you can have a real quick time. And this is a chemiluminescent response. There's other ways to look at it, and some you can use magnetic beads to pull out of solution where they're all mixed, anything that might have bound, whether it's patient or your others. So these are the ones, and then you're going to get a signal related to that. So there's a lot of different ways to look at somebody's antibody status. But this is what, so we talked a lot about like how you can get the signal, but this is the signal. So you'll have an absorbance signal and you'll have a cutoff. And they will either be a reactive or positive patient or a non-reactive or negative patient based on color, chemiluminescence, or fluorescence. It's either there or it's not. Now, some people are real close to the cutoff. Next week, they'd be positive. This is the thing we deal with. If you have a person who is positive, then you need to repeat that in duplicate just to make sure you got the right tube before you start telling the patient they look like they're HIV positive. Okay, and you can do reactive or non-reactive, same idea. You know, different combinations. So you can have a lot of false negatives. You can be way before you seroconvert. So anytime you get sensitized to something, your immune system has to say, well, let me catch up with this. But you can be before that so-called window period. So you're infected, but you're not showing signs of immune response to that infection. But the virus is setting up shop. You could have a B lymphocyte dysfunction. I don't make antibodies at all. So you wouldn't make them to HIV. Bone marrow transplant or otherwise. Technical errors, you know, if you did the kit wrong, those are false negatives. False positives, not as usual. But here's one that's really big. And we get this all the time. I got this last week. Presence of autoreactive antibodies. So for instance, if I go back a couple and say these antigens are grown up, because we're in 4th and 5th generation. So they're grown up, they're synthetic, and they're sitting here, and they might have some lymphocyte lineage to them or some other proteins to them. And we have had patients. So here's my scenario. We gave a unit of blood to a kid. The blood center said this donor tested positive for HIV in the screening test, but has no risk factors. Never tested positive before. And I said, okay. And when they did that, they basically said, we're going to do the nucleic acid test. So I didn't tell the mom about the kid and the blood yet, because they were still testing the donor. So what they did is they ended up doing nucleic acid, totally different than this. It was negative, and that trumped this false positive. So we didn't call the person false positive to alarm the patient. We looked at the donor and said the donor is truly negative. Because if there's no nucleic acid, there's no virus. So nucleic acid is the definitive test. But it shows you how proteins can be positive and you can be false positive. I've seen it in autoimmune disease and other autoreactive antibodies. It was back about 10 or 12 years ago. People with flu vaccines were getting false positive HIVs. And it was just because their immune system was reacting to the flu, and they made some broad reacting antibodies that stuck to these wells when tested, if tested. Donors of blood, someone who got their needle stick, and it was related to just their immune system. Here's another thing. We really have a low prevalence of infection. So, when you have a real high prevalence of infection, then, positive predictive value is pretty easy. But when you have a very low prevalence, then you're looking at, are you looking at false positives or other things? And so you have less false positives as you have a higher incidence. But false positives are possible when you have a very low population or low prevalence. They mean a lot more if you call them false positive when it's a low prevalence. And we have a low prevalence of HIV. I mean, it is low. And so you don't want to get it wrong when you call someone positive for their sake and for anybody they would expose, like a needle stick, like a healthcare worker, like a patient, like a recipient of blood. And this is just sensitivity versus prevalence. Kind of how our tests work. We would love our tests to be very sensitive. I find disease, very specific. It really is disease. So sensitivity is, I'll call everybody positive. Well, how many are real true? And then your specificity is low. If your specificity is really high, then they'll go, how many did you call positive? None. But when I call it, it really is. You would love it to be sensitive enough to pick some up and be very right as many times as you can. So when you get to other populations, other areas, going out in the rural US, going out in third worlds, going out in mission trips, going out in big populations or otherwise, this is another way of doing HIV. And this is doing HIV when you don't have the big machines and you don't have the instruments, and it's a multi-spot rapid test. And in this case, you're looking like the same test that we've done for years. And now people know how to do COVID, know how to read these lines, know how to look for migration from the control tissue to otherwise. Love to call a control positive because serum has been applied, and love to see a second part be positive because that's the specific antibody. So one is that specimen has been added, the appropriate specimen, and the second is that it's positive. And so again, what you're doing is you can do it with a secondary detection agent that would develop color here. Again, related to the presence of antibody here as a capture. It says, hey, I put a specimen on there and it was serum. And here I put a specimen that has this specific antibody for HIV. And by the way, it's positive. And so we're used to reading those kind of tests. And so what are you doing here? Well, you're not doing whole blood because whole blood wouldn't let you see the color, but you can do plasma. And through that clearness with the application, you're going to see that color. When you do the mucus of coronavirus, you're doing your secretions and you can see through that. Okay. You do urine in a pregnancy test, that's clear fluid. So whole blood usually is broken down into its parts in order to be able to at least see the detection. So those are all antigen antibody reactions, just like we talked about. That's the first thing is the virus will set up shop. RNA would be your earliest, but we can't test everybody for RNA. So can we get them for the first protein, which is P24 antigen? Can we get them for the first antibody, which is a little while later, which is antibody. So antigen antibody. But if I want to go back and get RNA and try to get a probe to detect RNA and say, you know what, for this mom, I need to know if she's positive. For this baby who won't make antibodies and mom is positive, I want to know if mom's positive and baby's negative or mom's positive and baby's positive. Well, mom has an antibody, plus she has our RNA. So we have the NAT test or the nucleic acid for the RNA. We have antigen tests that are positive when she was making antibody. Now she has a kid. So is this kid need anti-HIV meds? Are they infected or not? And that's where you're going to have to say, I want to see if there's any RNA in the baby's serum plasma. And you are going to, again, lyse the cells. Why do you lyse the cells? Because if it's in the cells, I need to get the virus out. It's like shaking the cells out. So I can get what's out there. But if you give me whole blood, I can like shake out all the circulating lymphocytes. And I have a target RNA. That's what I'm looking for. And I'm looking for that with a primer. So I'm looking for a primer that's going to amplify that target that's there. And when I amplify that target, and I get an RNA DNA, I can make DNA or copy DNA. And depending on how many times it goes around, I can make more and more copies. And so that's PCR, polymerase chain. It's going to create a reaction that's going to create a large number and be able to be detected. So you're going to detect it by a probe, amplify it by a probe, and then detect it. I'll show you some other ones. These are other types of amplifications. So now we're back to the gene level. We don't care about the protein. I don't want your antibody response. Too late to wait for that. Or let's take a kid. Kid's not going to make antibodies. P24 antigen, little late. I want to make sure I get the kid anti-HIV meds after birth if there's a risk. So I'm looking for one copy of the virus. So I'm looking for its nucleic acid. I'm looking as early as possible, and there's your reverse transcriptase. And you can see there's different types. You can either reverse to make DNA, copy DNA, or you can actually amplify the RNA. So there's a couple different ways to do it. But the big thing when you do it is the idea that you have to be able to have the primer recognized or not recognized. In other words, no polymerization if it's not there, amplification of polymerization if it is there, and then detecting it. And I think I have another one about the detection. And you guys have done this. I'm not going to flavor this one, because I think you guys have done the molecular techniques of probes. But the big thing is when the probe is in and you have a released chromogenic probe, if you are going to get displaced, if that probe does for reverse primer, so this is the probe, this is the primer, if there is copying, it will be released. So copying will send that signal out. And sometimes copying will internalize a signal. Either way, you're looking for some incorporation or breaking out of that signal to say it found its copy, it's making copies. Okay. So there are a lot of different, I don't know if you went upstairs and saw anything, but there's a lot of different machines on which this is based. Very different than your immunology, where we're just looking at the color change for the presence of antibody or antigen. These are now going to be sterile. These are going to be in an air controlled environment, because you want just the specimen from the patient to be introduced. You don't want any cross contamination. You can quantify HIV. This is used a lot in HIV treatment. So if you're going to change somebody on medications, you can see how much HIV they're making by quantitative PCR. So then we get into rapid tests. So if you're in, just like we talked about, if you're trying to test the patient, like in a clinic where they may not come back and you have just today or otherwise, now you're looking at even smaller kits that would allow you to look at color development, to find antibodies, because you have antigen on the surface, to add whole blood, in some instances, oral fluid as well, plasma that you can see through all the different types. And you can see you can hold these things for a couple of years in some of these areas. And you can do it by finger stick or otherwise. So these are rapid screening tests. And these would be, some of these I think are even available to individuals as opposed to just office settings or things like that. Same idea, antibodies, quick detection. Here's a 2-minute, here's a 20-minute, where you're looking at developing the test well right in front of you, that you would be able to see that. And you can see where you would have a control or you would have a patient. So the control would say, yes, you have put on the appropriate serum or plasma. We've detected IgG, for instance, or otherwise. You've charged the well and put stuff in the well. And then the patient would be in another area, yes or no, based on specific antibodies to a specific antigen. And we already talked about the multi-spot. Okay, because that one helps with HIV 1 and 2. There's different ones for HIV 1 and 2. So you can see where that would work in. clinics and in hospitals and otherwise in Africa, or in, South America, or the Caribbean, where both are prevalent. And so I'd like to look for antibodies to both. All right, so here's HIV and blood products, even though we were talking about it. The risk is low. And you can see that even in patients who have P24 negative, so they haven't even made that intact virion, they could still have HIV, and then, they could still have HIV. And again, we're upwards of 15 to 20 million donations a year. But here's what happens to HIV. So here's everything in a nutshell. T cell, macrophage, receptor, GP41 to 120, binding. And think what happens. I mean, what are your lymph nodes important in doing? What do they do? Like, what do they do? Even my lymph nodes are small. What do they do?
Filter.
Filter what? Yeah, I think that's a good way to put it. It waste. Arteries will head out, veins will come back, but within the interstitium, which is all the tissue in between the cells or otherwise, if any material gets out of blood, it starts to bathe the cell, including wastes, including damage, including cleanup from it. It's going to be in there, and it's going to come back by lymphatics. So lymphatics come back, and they'll ultimately join the blood, but they'll join the blood after filtration and after going through, and they filter through the lymph nodes. So if I have a cut here, my lymph node swollen up here, then everything from that damage, blood going there, and you go, wow, it throbs. Yep, that's your arterial blood coming in, and the venous blood's coming back. But you go, my finger's swollen. Well, that's swelling, all that tissue fluid, all that waste, all that damage, when it kind of comes down to a low level, is going to drain to the lymph nodes. And in the lymph nodes, they'll say, anything foreign here? Anything we have to react to? Anything that came from the outside through that cut? Anything that was introduced? And that's what will happen. So put yourself in a mucosal surface with blood splatter, a hollow needle, got the introduction into blood system. To the lymph node. It loves T4s. Where do T cells live? In the lymph nodes and a lot of other tissues. So you bring it right to the factory and it goes, this is fabulous. I can be presented as a foreign antigen while I'm also infecting all the other cells around. So there's the binding, and there's the release, and there's the virion headed in. And when it heads in, this is the viral genome. This is the reverse transcriptase, and it is this copy DNA that goes in. This is now a virally directed and infected cell. It's trying to do what you're supposed to do, what the T4 is supposed to do, but it is really more bound to make copies of the virion RNA, use proteins to synthesize, and out come virus. So it's turned into a virus factor. It still tries to do its job, and here's what happens. So you get the primary infection, it drains to lymph nodes, and within the lymph nodes, you establish your infection. So you may not have virus yet or otherwise, but then you start pumping out the nucleic acids. In other words, the early virus. You may even have P24 antigen. And now here comes your immune response. So you're going to do two things. T8s are going to try to kill the T4s. Wait a minute, that's not usual. And T4s are going to help make antibodies. Okay, that's usual. And you partially control this to a point. And you go into a latent stage, real low level infection where most of the T4s are killed and the healthy T4s are helping to make antibodies, but there's probably still some T4s left. And ultimately, you can get replication and T4 damage. And here's what happens. The T4 is infected. Okay, so if the T4 is infected, it sends up a little flag of infected. The T8 say, well, we'll kill you. Down go the number of T4 cells because of your T8. So that's a loss of T4. Another, viral replication took over the T4 to the point where virus goes out, T4 is dead. Decrease in T4 for this. Decrease because the HIV uses it. Decrease because the immune system kills them. T4s are starting to fall away. Then you have T4s that have a little bit of virus in them, and they're going to try to do what they need to do. They're going to get activated by infection. They're going to get activated by, you know, your immune system, because every day your immune system's reacting to something. And even with activation, they can undergo apoptosis because they're not the healthiest T4s, and also uninfected T4 cells can die off in the process of doing their work. So here's what happens. And this is what used to happen before we stopped HIV from replicating. We didn't even talk about that. So you come in, you have the RNA, you take over your cell, you make the virus, you make the antibody. We go all the way back, making that virus is like, wow, you're infected, but you're not showing any signs, but T4s are infected. Now, the question is, can your body kill off all your T4 cells? Are a lot of your T4 cells infected? Yes, it could be. And no, it's probably impossible unless you're going to be T4 depleted. And that's the end stage of HIV. So how do I do this? Well, every time one of these things happens, hopefully I can negate this by some of the medications that stop the replication. So now the T4 goes, do you want me to make it or not? HIV goes, please make more copies. Your drug says, stop making copies, and I'll show you the drugs. So if you stop making copies, you'll have infected cells, but instead of the infected cells giving a lot of virus, they'll sit here and be destroyed. But what happens if they give off virus? Then that virus in the lymph node could say, well, there's more T4 cells I haven't infected. This is perfect. I'll just keep spreading. This is absolutely fantastic. And then the T8 goes, I'm gonna have to kill every T4 cell that you have. So what do you do here? You're saving the viral particles by stopping and that's the thing that has changed in the last 20 years of HIV. That's the reason that people with risk factors for HIV are back in the blood supply as of about 6 months ago. They're back in the blood supply because of living with low levels of copy, being protected, not having that issue. But we didn't have that. Let me show you what happened before. Here would come your primary infection. Okay. And in this particular case, you are looking at virus. So notice how the virus spikes at the same time your CD4 cells take a little bit of a hit. So they get infected, maybe even get used. Virus goes up. This is the acute, this is the mono. And then the T cells kind of respond. And with the T4s there, here is your virus. Okay, so this is your viral antigen. So the T4s respond by helping you make antibody, and the T4 cell, the cytotoxic lymphocytes are going up as well. So this is your immune response here. So it took a hold. Now your body's coming to the rescue. But here is what happened in HIV untreated. Eventually, look what the T4s do. And they get to the point where they can't support any immune function. Don't make antibodies. You get opportunistic infections. You don't have any T4s anymore. And look what then happens. HIV would say, well, now I can be unabated. And that's how we would get death way back when. So, and here's what happens again. All of these would stay up for a certain while, and then here comes the viral particles again. So HIV would win because your immune system would lose. You would die because your immune system was gone. So this is different than any other viral infection we'll talk about. This is a viral infection of your viral protective mechanisms of your immune system. So it's like a snake eating its own tail. You'll go, oh, he's got it. Yeah, wait a minute. I mean, eventually it does the host in. So what has happened since, as far as treatment goes? So now you started off with, the epidemiology. There is a blood exposure. That we talk about wastes and materials in a needle stick in the first lymph nodes. Those are where T4s live. T4s are the cells that get infected. Some will get infected. T8s will kill them. Some will be factories. They'll die. Some will be. What can you do? If I can decrease the amount of virus. So there are inhibitors of entry that would stop the virus that just got made from going to the neighbor T cell. Okay. And when we talk hepatitis, that's what happens in hepatitis. You take over one cell and it goes, this is phenomenal. I'll just make, and it'll be all my neighbors. And then your body goes, I have to kill all of this. because now that your immune system got started a little later. So think about it. What do we try to do when we give you a flu vaccine? We try to prevent it from getting into the cells. We try to neutralize it. So there are entry inhibitors. It could get in, but we could stop with reverse transcriptase inhibitors. People are on that. You could do integrase inhibitors, stops it from going in the DNA. You could do protease inhibitors. You've heard a lot of that with viruses. And so that stops the proteins, that stops making the virus. So what you do is you say, yep, I'm sorry it's a virally infected cell, but that virally infected cell will make no more copies. It will not promote another cell from getting infected. So the infection stops here. And that's what happened. And that's what you see Magic Johnson 35 years later, because he has been privy to numerous stages of medications. The question is, do you ever get cured? Or if you go off of this, if you go off of any of these, will you allow it to come back? And no one really knows for sure. And they believe that if you do come off of it, it will then get a hold just like it would if you had not had the meds. So you can block certain, and I'm just going to show you a lot of pictures, but what are you blocking? If you look at this with A, G, C, T, and why would we say that? We're saying that for RNA. Many of the drugs look very much like them. And these are the ones that can get, these are the ones that if you look can block RNA because they basically go in, but they're not exactly the same. And it can almost terminate the process of RNA, making it dysfunctional. Other ones can bind the reverse transcriptase. And again, these are the ones that bind the transcriptase. And they're binding it similar to other nucleic acids they look like, but they're terminal. They stop the process. Protease inhibitors. The protease inhibitors happen to be these. And if you think about it, and you're probably putting this in your mind, anytime you see Vir, you're looking at a protease inhibitor. So when you see those names thrown around, so let's not make the protein. So the virus, the cell's infected, the cell has to die, but the cell will not pop out intact virus. Okay, and and then there's entry inhibitors where you're going to bind the GP41, just like binding the spike protein in a coronavirus. You're preventing it from getting in, and those will just bind. They'll just be more conformationally like a T4 antigen. So anyway, but so what you get nowadays is drug resistance. So we're so good at getting people to live that viruses and bacteria love to live too. And so when they sit there and get used to the antibiotic you're giving them, bacteria, or the transcriptase that you're giving them for the virus, they go, yeah, I think I'm going to mutate and go around this and get around everything you're doing. And it can lead to viral replication or mutants. And so now we do resistance testing. So here's what we used to do. Antibiotics, and we would support people and hope they wouldn't die with low T4s. Then we got all these materials to block entry, to block DNA, incorporating in the DNA, to make protein, and all of those that stop the infection. And now we're going to the point where we're taking HIV infected patients and making sure they don't have mutant forms, which would make them progress in their disease going around all the treatments that we have. So it's like resistance testing. And so now we're testing for virus. We're testing for the load of virus, not because they're infected, because we want to know if we've shut it all off. And if we shut it all off, then they're making very little virus. That means in a potential that their body catches up with all the infected cells. Okay, and they're the worst ones. And T4 is the big one. And they're considered killed, rendered non-functional, used and abused and thrown away as a result of HIV infection. And so many people have their T4 cells. In fact, we just got flow cytometry, and we're going to do T cell subsets and B cell subsets. We're not going to do them for HIV. We're going to do them for kids who don't have good B and T cells because they're born with an immune deficiency. But other places will do T4 cells just for pure number because it makes a difference. What's the number one thing, you probably don't know this, but what's the number one thing you're going to see in a CBC? in an adult patient. Low white count, but specifically low lymphocytes. You'll see it all the time because steroids or other medications. But if someone walks along, I have a friend who keeps calling me, she goes, my lymphocytes are 600. I go, how do you feel? Good. Do you have any risk factors? No. You can call me next year. And she calls next year. She goes, my lymphocytes are 750. I'm like, how do you feel? Good. Do you have any risk factors? No. Okay. Because she just lives at that number. But what if someone is at 200 or, the lymphocytes are really, really low and they don't have a cause for it? That's the reason we would look for T4 cells. We don't know the patient. You have to ask them their risk factors. I don't know what the risk factors. So that's done by flow cytometry. You should have 2 T4s for every 1 CD8. T4s to THV 2 to 1. So if I flip that ratio, I have more CD8s, or if I don't have any CD4s, then I'm starting to worry. And then, this is when they used to do therapies and decide when they'd initiate therapy. I think the biggest thing you guys will see is needle sticks and blood splashes. If you have a needle stick and a blood splash, they will draw that patient, not knowing. So you're in the ER, you go down, you go to get someone, you're starting to inoculate. For some reason, you didn't cover the needle, you get hit, and you're like, oh my gosh, they don't know anything about the patient. You report to employee health. They're going to say, you potentially just got inoculated. So they would probably give you many of these blockers to prevent infection into your T4s and everything else while they're saying, let me test this patient. So what are they going to test the patient for? Nucleic acid, HIV antibody. And what are they going to test you for? Nucleic acid. Why not antibody? Because it happened today. Okay. And then those are the things. So if the patient's negative, they'll go, you're done. Patient's positive for hepatitis, they'll go, did you get a hepatitis vaccine? Yeah, you're done because you're protected. Okay. So that's the blood and body fluid that we deal with. Why a splash in the eye? Well, if you're like me and you flake all over in winter, dust is actually like 75% human cells, believe it or not. So we get dry. But you have a protective layer of keratin on your skin surface. You have to poke through that. But your nose, your mouth, and your eye is a mucosal surface. So your antigen presenting cells are going, wow, blood can get there and just diffuse right in. So blood splashes are a way. You're opening your mouth and you get hit with blood or whatever. That's the reason we will work under shields and we'll work under hoods and things like that. Why is a hollow needle? Well, now I took my intact skin right through the hollow needle. But if I have a Band-Aid, I better wear it over a cut because now I've compromised the surface. So your skin is protective. Okay. That's the mucosal. So that's where you're going to run into HIV a lot now. Is the idea of be careful, treat everything as infected because that's just good form. That's probably where you'll run into it more than anything else, to tell you the truth these days. So acquired immune deficiency was you acquired an immune deficiency state because you have no CD4s. And at certain points, they're going to get more and more types of infections. CD4 count's a big one. And again, why the CD4s die? Virus uses them and throws them away. Cells die off because they're infected and abnormal. I don't think we put it here. Redistribution and decreased production. But what about just T8 attack? The T8s are doing their job. The immune system attacks the immune system to its detriment. So here it is again, used and thrown away. Hopefully we treat this with a lot of those blockers. No more virus comes out of the infected cells. Then if they move over here as non-productive infected cells, you go, you know what? Let's lose them. Let's get rid of them. Then you get rid of the infection or a lot of virus. But it's the CD4 that's the solution. Okay. Want to take a stretch for like 10 minutes? How about questions? All right. So the goal of any viral infection is detect. So let me throw these out. What is the longest detection? Nucleic acid, protein antigen, or antibody? What takes the longest? Antibody. You need to have an immune response before you make an antibody. You get stuck today, you don't have an antibody. 6 months later, you do. but I've lost the chance to treat. Okay. What's the earliest and the best detection for a lot of viruses? Nucleic acid. Do we have nucleic acid for a lot of them? We don't. Do we develop for corona? Yeah. Do we have them for hepatitis? We do now. Other ones we may. So how do we test for mono? You know? What do we call it? You know the
Titer.
test? Well, you can get a titer, but what do we call the test? You may not know this. and that's okay.
EBV.
Well, it is EBV, correct. We call it a monospot, if you've heard of monospot. So a monospot basically has this antigen and says, does the patient have antibody? I feel like crap. Yep, you got mono. I can then go to a machine and get your titers, like you were saying, and get an EBV viral capsid antigen antibody. I can see if you're IgM positive, you had it last week. IgG positive, you had it 3 or 4 weeks ago. Okay, but the monospot is like those HIV blot spots. You go, let's put that on there and let's see if you have an antibody to it. Okay, so now think of mono. Do we ever do a nucleic acid? We always do antibody. By then, half the class got mono. My nephew has mono now. It's like, all right, was it prom? Was it going to homecoming? Was it basketball and everybody drank from the same? And this is possible. So those are the things. And so it's very interesting when you go from virus to virus, asking yourself the question, why are we trying to detect it early before antibody? Why are we only looking at antibody? Are we looking at early antibody IgM or late antibody IgG? Do we care that you ever had mono or not? Well, all your antibodies are negative. It's not mono. So your body tells stuff serologically, tells what it's been exposed to. Okay, so if you sat there and said it looks like mono and you do IgG and IgM and there's not a bit of Epstein-Barr IgG or IgM, and now you're off to maybe it's CMV. So the different patient populations have different waiting periods. You can't wait for a bone marrow transplant patient to make an antibody. And you desperately need to know if they have CMV. So you may be at an antigen test. You may be at a nucleic acid test. That's why the difference between molecular and immunology. Immunology is you. And it's a little while after infection. Molecular is right after you got exposed and infected. Does that make sense? Let's take 10. I don't think there's any air moving.